When discussing fluid volume imbalances, we are talking about extracellular fluid or ECF. When the body has too much fluid in the ECF, we call this fluid volume excess or hypervolemia. On the other hand, when there is not enough fluid in the ECF, we call this fluid volume deficit or hypovolemia. Remember that hyper means too much and hypo means not enough. Approximately 60% of an adult's weight is made up of water, and this amount can vary based on age, sex, and body mass. For example, a man with a high percentage of lean body mass will have a higher percentage of water compared to a woman with less lean body mass. As we know, when people age, there is also a loss in lean body mass. This means there would also be a smaller percentage of water. So where is the 60% of water located? Well, approximately 2/3 is located within the ICF, and the other 1/3 is located in the ECF. Within the ECF, it is broken down further, with 1/3 of that being located in the plasma space, and 2/3 of it being located in the interstitial space. When a volume deficit occurs, water leaves our cells and causes them to shrink, and the cells may die. On the other hand, when a volume excess occurs, the water rushes into our cells, causing them to expand and possibly burst. In either of these cases, our cells are not able to function properly, and damage may be irreversible if not corrected. Consider the different cells within our body. If this happens to hemoglobin, what can occur? Hemoglobin is responsible for transporting oxygen all over the place, and if those cells aren't working properly, poor tissue perfusion can result. Also consider the cells in our brain. If they are swollen or have shrunk, this can be responsible for confusion or a decreased level of consciousness. We should also talk quickly about fluid spacing. Fluid spacing refers to where the water in our body is located. First spacing is when the water is exactly where it's supposed to be. Second spacing refers to edema, when we have an abnormal accumulation of interstitial fluids. And third spacing happens when water gets to where it isn't supposed to be, and then it gets trapped there, making this fluid unavailable for the functions of the body. Risk factors or causes of fluid volume imbalances can vary greatly. Hypervolemia can be caused by disease processes such as heart failure, kidney dysfunction, and liver disease. The long-term use of corticosteroids can also lead to hypervolemia. Excess sodium intake and excess IV fluids can also cause ECF volume excess. Although rare if the kidneys are functioning properly, an excess intake of fluids can cause hypervolemia as well. Hypovolemia has a variety of causes as well, such as reduced intake due to nausea or an inability to drink. ECF volume deficit is also caused by losses from hyperventilation, vomiting, diarrhea, excessive sweating, increased urination due to diuretics, or NG suctioning. Additionally, disease processes such as diabetes insipidus, kidney disease, and diabetic ketoacidosis can cause hypovolemia. It's also important to note that trauma that causes hemorrhaging or burns can cause hypovolemia quickly. What are the signs and symptoms of hypervolemia or too much fluid? Well, we are going to see things like hypertension, bounding pulses, and distended neck veins because more fluid equals more pressure in our system. With excess fluid, we will also see changes to our respiratory status due to pulmonary congestion and edema. And because of that, be on the lookout for shortness of breath, coughing, and you may be able to hear moist crackles when you listen to the lungs. Neurologically, we may see the results of cells in the brain swelling, which would lead to headaches, weakness, and confusion, to name a few. Weight gain and edema can also be signs of fluid retention that signifies fluid volume excess. When experiencing hypovolemia, we should also expect changes with our cardiovascular system. Hypotension, weak pulses, and flattened neck veins result because of less fluid volume, and tachycardia because our heart is working harder to pump less fluid around our body. An increase in our respiratory rate happens because we have less fluid circulating and we may be experiencing a decrease in tissue perfusion. Look for a slow cap refill. Neurologically, we may see the results of cells in the brain shrinking, which would lead to tremors, restlessness, agitation, or even coma. We would also see a decrease in skin turgor. When pinched, the skin may tent and not return to its original placement right away. We may also see dry mucous membranes and a dry tongue. Patients may also complain of thirst. Proper assessment should always include a full health history to determine if there are any risk factors that may be causing your patient's symptoms. Make sure to get a full medication list from your patient, as well as asking them how much they take and how often. Maybe they are on diuretics and not taking them properly. Next, we could move on to a full head-to-toe assessment. This is where we would discover most of the signs and symptoms and verify the patient's reason for seeking care. It's very important to do a visual inspection. Does the abdomen or neck veins look distended? Auscultation. Do the lungs have crackles? And palpation. Does the patient have pitting edema or is their pulse bounding? We should always be looking to our lab values as well to help us discover the cause of our patient's symptoms. Discuss the patient's eating and drinking habits, as taking in too much or too little fluid can cause an imbalance. Finally, discuss their elimination habits. You may find that they are urinating frequently, or perhaps they had a bout of diarrhea recently. Make sure to ask them what is currently happening and if this is normal for them. Remember to always ask about any recent changes, as this information may give you clues as to what is happening and why. Our main diagnostic tests are going to be our lab values to look at electrolytes and dilution of our fluids. In hypervolemia, our fluids are going to be diluted because of all that extra water in our system. Due to this, we are going to see a reduction in our lab values. You may see the following lab values decrease: hematocrit, ADH, BUN, sodium, potassium, urine osmolality, and urine-specific gravity. In contrast, hypovolemia, our fluids will be concentrated because we don't have enough water. Therefore, we will see an increase in our lab values. You may see some of the following lab values increase: hematocrit, ADH, BUN, sodium, potassium, urine osmolality, and urine-specific gravity. Diuretics are the most common medication given in the case of hypervolemia. Diuretics act on the kidneys in order to increase diuresis. There are three main classifications of diuretics: loop diuretics, potassium-sparing diuretics, and thiazides and thiazide-like diuretics. Loop diuretics are often indicated because they are able to provide rapid diuresis with a rapid onset of action, and the effects last for at least 2 hours. Electrolyte lab values should be monitored during diuretic usage, especially with IV administration. Electrolytes such as potassium or sodium may need to be replaced. With hypovolemia, we need to replace the fluid that was lost without upsetting the electrolyte balance. For this reason, crystalloids such as normal saline, lactated ringers, or dextrose 5% water are often given. When the loss of fluids is from the plasma space, colloids, also known as plasma expanders, are given. Examples of colloids are dextran and albumin. When hypovolemia results from a loss of blood, blood products are often administered. Packed red blood cells are generally given when blood loss is up to 25%, and if it's over 25%, then we'd be looking at giving whole blood. Fresh frozen plasma can also help because it can increase clotting factors if the patient's hemorrhaging is ongoing. Some of our nursing care is going to be based on what is ordered by the primary physician. When administering diuretics, we are going to monitor the patient for drug effectiveness and monitor the output of urine. We will assist our patients with skin care and ensure no skin tears occur during repositioning. If the patient is experiencing edema in their lower limbs, we will elevate the legs when resting and encourage mobilization. If the patient is also experiencing shortness of breath, we may also elevate the head of the bed and administer oxygen as ordered. When IV fluids are ordered, we will ensure patency of the IV site and appropriate infusion rate. Keep in mind that IV fluids should be running continuously, so the patient may need assistance with mobilization and getting to the bathroom or using a bedside commode. Once again, skincare will be a priority as well. Applying lotion and frequent repositioning will help provide comfort and maintain skin integrity. Patient and family or caregiver education is very important. Information should be given regarding any risk factors that the patient has and signs and symptoms that they should be aware of. Upon discharge, it is also very important to discuss medication usage. Patients must know what they are supposed to take, why they are taking it, when to take it, and how much to take. Older patients may be encouraged to contact their pharmacy to see if blister packs are available for their medications in order to improve medication adherence. Next, intake of fluids and certain foods should be discussed. If the patient is on a fluid or sodium restriction, this should be discussed with them as well as ideas on how to measure and limit their intake. Finally, self-care should also be discussed. If a patient is going home with pitting edema in their legs, they should be instructed on how to care for them. Elevation combined with mobility, even if it's only heel pumps, should be discussed and/or demonstrated. Application of lotion and avoiding shearing forces, as well as frequent repositioning, should also be discussed to reduce skin breakdown and injury. Complications can occur with both hyper and hypovolemia. Look for changes in blood pressure, tissue perfusion, heart rate, respiratory rate, electrolyte imbalance, and level of consciousness. The most severe complication to watch out for is hypovolemic shock. Hypovolemic shock is broken down into two categories, absolute and relative. Absolute refers to actual fluid loss, such as hemorrhaging, and relative is when third spacing occurs and fluids move into areas of the body where they are inaccessible by the cells to perform their functions. When this occurs, there will be decreased tissue perfusion, cellular dysfunction, and eventually tissue destruction. This is a life-threatening condition and must be treated in a timely manner in order to reverse the effects and prevent irreversible damage. Summers states that it is essential that nurses are able to identify patients at risk of hypovolemia because early intervention can prevent the patient from developing hypovolemic shock. While this topic is lengthy enough for its own presentation, the important signs to watch out for are a narrowing pulse pressure, decrease in bowel sounds, which may progress to a blockage, decreased level of consciousness, restlessness, confusion, hyperventilation, and skin that was once warm and flushed is now cold and clammy. When hypovolemic shock is suspected, get help immediately and consider calling a code for that immediate help if the patient is critical. Start 2 large bore IVs for rapid fluid resuscitation. Apply a blood pressure cuff to obtain blood pressure readings at set intervals, and initiate a urinary catheter to monitor urine output.